Welcome back and thank you for staying with KTN Prime. Now we want to find out what exactly is ailing our health sector. A lot has been happening, from ghost hospitals to allegations of fraud. What exactly is happening? Not forgetting about the UHC. All this we want to converse right now, and joining me for this particular conversation to my far right is Christine Sadia, the chairperson, Kenya Medical Women Association. Good evening and thank you so much for making time.
Good evening.
Next to her we have Reverend Joseph Kariuki, who is the vice chairman at the Rural and Urban Private Hospitals Association, also known as RUFA. Perhaps let's start with RUFA, because you have been vocal lately, and you have been accusing the Social Health Authority of deliberately trying to cripple private hospitals through non-payment of claims. You further alleged SHA automatically rejects claims from private and faith-based facilities while prioritizing payment to public hospitals. Let's start with you painting a picture of what exactly is happening.
Thank you so much, Ashley, and good evening, viewers. Explaining the health sector at the moment, it's like you're telling a story that everyone understands. Of late, in the recent weeks, the SHA thing and the health sector issues have been on the media, social media, and everywhere. And it's good to say that things are difficult, especially for the providers, but we are up to speed. We are trying to work out things. Despite the challenges of delayed payment, the challenges of rejected claims, the challenge of accusation of fraud, we are still coming up and we are still seeing our patients, and we'll continue to do what is good for this country.
Have services been disrupted?
Yes, to some extent. We find that there are some places where we are not able to offer services because of cash flow issues. And so when clients come, we just tell them we are not able to do much.
Okay.
Yes.
And where does that leave a patient in such a situation?
It's so sad, especially for providers, because our calling first is to give service to the people. And when you are not able to do that, and simply because you are not able to buy your supplies, it puts you in a very precarious situation.
Okay.
Yeah.
Ma'am, coming to you, you're the chairperson of Kenya Medical Women Association. How are women, not just women, but equally youth, affected by the challenges bedeviling the health sector?
Thank you very much for that question. In any health care delivery system, when there is a disruption, or the people that are normally left behind are women and young people. We have seen of late, when we did a quick analysis of what was happening in the sector, that since the transition between NHIF and SHA, as much as there was a period of hope that we thought things were picking up, of late, with the kind of noise and what is going on and the mistrust that has been created, it looks like the women are not now being served adequately. The access is not good. Quality of care is not as good as we would want it to be. But for the young people, I think the thing that SHA was supposed to cure was to have sustainable financing, or to alleviate the issue of out-of-pocket expenditure. The out-of-pocket expenditure has already gone up. So you find that if you have young people who are equally not employed, they have no money to pay for the services as they go, then that means the care is delayed, and therefore they are not getting care. So we can't say for sure that we are in a good space. Yeah. And now with the recent, what is going on, which my colleague has just talked about, when you shut down some of the facilities, and already we started from a point of deficiency, then the people around that catchment area definitely have no facility to go to. So I think it is something that we need as Kenyans to work on quickly, so that we can catch up and move forward.
Okay. Yeah. You've raised very important issues, and SHA was equally supposed to usher in a new era of transparency and accountability. Perhaps with everything that we are seeing, do you think the transfer process was flawed?
I think about 6 months ago, before it was launched, already the health economists and people who are in policy area like myself had already raised an alarm that the rollout was being pushed much faster. We needed to have done things so that we were sure that when we launched the rollout, that the rollout would be a little bit seamless, even if it wasn't 100% perfect, but it would be near perfect. So you correct as you go. But I think the rollout and the launching was done so quickly without people understanding and even the preparation. So even when we are talking, some of the providers don't even actually know when we are accusing them that there is the system, the digital system is not keyed in properly, and perhaps is what is, some could be overt fraud, yes, we can't rule out overt fraud, but then there could be some mistakes that with training and capacity building should have been averted. So if that preparation was not done and people were confident, the health professionals were not confident of what they were launching into, then you find that mistakes are likely to occur. Okay. And the interpretation of that mistake could be either what is now coming out as fraud. They could be also overt, because somebody is taking advantage of people who are not just confident about what they're doing at the key-in point, where at the service delivery point. So we didn't take care of the service delivery point and the capacity building. So I think there's a problem in that.
Okay, Reverend, coming back to you. I mean, yes, things are not rosy from where you stand, but if you look at RUFA in general, how many of your members have suffered this fate of, being told their claims are denied or rejected? And perhaps are they giving any reasons as to why these claims are being rejected?
Actually, quite a number. Actually, you can say there is no single facility, leave alone RUFA members. All facilities, especially in the private sector, that is not affected by these rejections and fraud allegations. Basically, almost 100%. And like you ask, are there reasons given? I can tell you almost 80% no reasons given. And the 20% reason given are very flimsy. One of the reasons that we saw in a facility is that the rejection was given because of inability to read the doctor's notes. Somebody who is verifying claim was not able to read what the doctor had written in the doctor's notes, and hence rejection.
Really?
Really.
Okay.
So you get to wonder, who is verifying the claims? Is just any other person or another doctor? Because a doctor needs to be, verified by another doctor. Some other reasons that you get is that there is no documents attached. And when you look at the claim that was sent, all documents are there. Some other reasons, we are told that there is no evidence of delivery, especially for mothers who have come to deliver. So you wonder, you have attached the birth notification for the baby, you have attached the mother's ID, the discharge summary is there for the process that was done, and then somebody asks you for evidence of childbirth. What evidence should we give? A video of a mother delivering or a picture? What evidence is required? So some of these things, again, are said rejected, no reasons given. Sometimes you find that when somebody has been admitted, 4 days going up, that is an automatic rejection without even asking a question or coming to verify. One of the problems we're experiencing is because as we sit, SHA does not have surveillance officers. There is nobody who comes to the facility like it used to happen before, the days of NHIF, to confirm, to go through the patient's file, to talk to the patients, look at whatever is being done. Nobody does that. And then somebody comes at the end of it to condemn the facility for fraud. And what you need to understand again is that this allegation of fraud comes when the process has already been completed, it is at payment stage. Sometimes SHA is supposed to pay within 90 days, but you find a claim has been there 120 days plus, and that is now when it's being rejected. Then you are wondering, what was happening throughout this process? What was the purpose of the 104 billion system? It was to verify all these things. By the time the claim is coming to payment, it is verified. But now a lot of these rejections are coming at the point of payment, which is very, very unusual. And there is no opportunity for redress.
Okay. And that's why you're pushing for dispute.
That's why we are pushing for the dispute resolution mechanism.
And we'll get there. Before we get there, for the sake of our viewers, because you're privy to this information, I want us to just go back to the defunct NHIF. You've talked about the fact that there were personnel who would come to the ground and clarify and verify. Where we are right now and where we were then, perhaps maybe you can give the disparities between the two processes, apart from just the issue of personnel and the fact that claims kept on being, like there was verification at each stage as opposed to what you've explained right now. What else is different between the two?
Actually, you know, we've been told that when you go back talking to NHIF, you are anti-development, you don't want to move, you're against the new things. But truth be told, there were very good things that were happening under NHIF. In the days of NHIF, all the processes were visible in the system, in the provider portal. You would see, once you have discharged a client, you will see where the claim has gone. You will see it up to the payment period. And all those stages were there, and everyone can follow, both from the NHIF branch and the facility. The surveillance officers and quality assurance officers would come to the facility and ask you for the patient's file, and they go through it, and they just check whether the treatment given is right and is corresponding to the diagnosis. All those things used to happen. And the issue of fraud was not there because you could finalize these matters right in the facility. And so when the claim passes the QA stage, it is almost like it is paid because it has been verified. Now, very different things with SHA today. That you put your claim, it gets into the system, you can't follow it. Just 2 weeks ago, they removed that part of the expected pay. It used to be there when they started. You can tell now, as a business person, I'm expecting 1 million shillings or 2 million shillings in the next few days. So, it can help in your budget. Now they remove that thing. Anything that is going to inform or make the system transparent, SHA is removing it. But the system for NHIF, until we closed, it was still vivid and clear, and everybody could see every stage.
Okay. I'm coming to you. I mean, yesterday we saw the health CS Aiden Duale submit files to the DCI. And there are those that are asking, so then, in this particular case, who is the weak link? Because there are those that are assuming there is a SHA board. And one of the core mandates is to oversight. Shouldn't we have started it at that level first?
Well, those files I saw, for me, I think as a retired medical practitioner, I'm not in clinical practice, but I do policy. Two things that struck me. One, when we have reached at the DCI, we've already accused somebody. Where is the evidence? And for medical practitioner, for medical systems, they are regulators. So are we saying that we are bypassing the regulators or the weak, the regulatory framework, the authorities that we have? For example, a doctor like myself, if I have made a mistake, which is technical, so I think we need to distinguish two things here. Is it a technical issue? Because I heard yesterday that some facilities are being closed. Closing a facility, having been a deputy director of medical services, closing a facility really takes you a long haul. It must be something that is completely outrageous. But also there's inbuilt systems like the Medical Practitioners and Dentist Board. If I have issues which are of clinical nature or professional nature, it needs to be sorted. But now, when we are talking about administrative and operational issues, what struck my head, is it the owner of the hospital, if it is a private one, or is it if it's a public one, then are there files, if they are public in those files, who then should have appeared in DCI or in court? The same people who are floating the files? I think for me, there are issues that we need to distinguish very clearly. The closure of a facility is the mandate of Kenya Medical Practitioners and Dentists Council. So that's clear. If you have a contract with, SHA has contracts with individual facilities, I think the best that you could do, if there is something that has not been sorted out now that the tribunal has not been set up, and you've locked horns or whatever, there must be a mechanism that only after evidence has been proven, then whatever cause. But I do not think that even it is premature you are still a digital space. And from what I heard, it was AI driven. And for me, I work in AI space quite a lot. The caution that it gives you, even when I do research using AI, I'm verifying things, it gives you, please go back to your system and check, because AI is not 100% accurate. Could it be that somebody maybe missed something, and because of the algorithm or because of what AI is pursuing, it is lumping? But I don't want to say that there's no fraud or there's no mistake. But can we set so that we do not log the services and stop services? Because stopping a service is something that is so crazy. Because, you know, people are already in the night, people are preparing. They know that is their preferred facilities. They want to go to their preferred facilities. You've closed them. What happens in the morning? I have a labor pain, for example. I want to go. And the next one, then the walking distance may be, how long? I could be walking like another 3 times. The next thing, I have no ability to pay for my transportation. That is now out of pocket, my out of pocket expenditure. I still don't have it. Maybe last night it was a woman who didn't even put food on the table. So I guess from what I saw was very dramatic. But when we have already escalated it to, like it is already termed as fraud, since when did health practitioners just come overt thieves when in their care? All of us. I think do not lump all of us. There could be rotten eggs amongst us, but isolate so that the right person, the blame is put on the right doorstep. Because what is now happening, we are going to stop the mistrust in this system. It's going to be so huge, and the demoralization of already the people that are functioning with goodwill to help Kenyans get health services are going to be so demoralized. Because if you have told us we are all thieves, we are stealing. And for me, I hear doctors. I don't know if everybody is the doctors who are stealing. I think there needs to be some sorting out that will be done. They can stop you from being SHA accredited in the meantime, but why stop before you get the evidence? Is the evidence there? Because if the evidence was there, why has somebody not been arraigned in court? I was expecting that today people will appear in court. Yeah? If the evidence to make a charge is already there, I was expecting people to be in court this morning. And I would have clapped very much, because me, I don't like thieves. So
perhaps, do you think the process is being weaponized?
Pardon?
Is the process being weaponized from everything that you said? I mean, there's so many gaps in the explanations.
But before you accuse, I thought you should have evidence. If you really know that there are people who have deliberately done the system so that they get their gains, why aren't we taking them to court? Because there's already evidence. But it can't be a facility. It can only be individuals within a facility. So who are these individuals? A facility cannot walk to court or cannot go to DCI.
I get it. Coming to you, Reverend, and speaking picking up from where she left off, there are those who claim the authority is being reduced to a mere rubber stamp. And MOH, together with the Digital Health Authority, also known as DHA, are accused of exercising undue influence over SHA. Do you think that could be the root cause of the problem?
Actually, a bigger part of the problem is that. You know, I've read several books, but one of the books that I love is by John C. Maxwell, where he says everything rises and falls at the leadership. So all this trouble we are seeing within SHA is all about governance, it's all about leadership. I'll tell you for free that SHA is among these bodies we call SAGA, semi-autonomous government agencies. You know, it has a chair, it has a board, it has management. Exactly. We are supposed to see more of these people because they are the ones who have been appointed as expert in that area. They are the ones who should be driving us, not directly from the ministry. We don't want to see any small circular for SHA is coming from Afya House. It's not right. It tells you there is a problem there. So governance issue. Again, DHA came to facilitate SHA to work, but now it's the opposite. We are seeing even the payments are actually determined by DHA and some other places, you know. So SHA has been reduced to a mere outfit. They are just flower girls in their own game. But when we come back to the issue of fraud, it's a very juicy subject. First of all, I need to start by saying that as an association, RUFA, we have a very strong anti-fraud policy. Very strong. That every of our members sign when they sign up for membership. And we have a responsibility and a committee within RUFA to follow facilities, especially when there are allegations of fraud. We really expected that all these 1,000 and whatever files that was given to DCI, the facilities would have received a letter first from SHA accusing the facility of fraud and allow the facility to respond because it is against the rule of natural justice to be condemned unheard. It is very, very wrong. The facility should have been written a letter. They respond to it, and having some discussion there, and the SHA feels there is still a problem, then that's when the problem can be escalated. That's one of the areas. And where do you escalate these problems of fraud? We needed to have the conflict resolution committee within the SHA. Actually, it is provided for in the Social Health Insurance Act. The MOH or the CS has not established that committee. And so when all these problems are coming, there is no place people can go. I do not know whether it is by design or just mere neglect. Secondly, Ashley, when it comes to fraud, I would like us to look at it internationally. And I'm glad Daktari has worked within the country and outside. And she can confirm this, that the best practice in insurance internationally, they always provide for 5 to 10% of the medical fraud factored in their losses. 5 to 10%. That is to tell you that medical fraud, less than 10% is what happens at the facility. Less than 10% of medical fraud is what happens in the facility. Now the question is, where does the 90% happen?
That's the big question.
Yes. So when we spend all our energy to pin down a facility, we are actually doing all that to find under 10% of medical fraud. We should be asking ourselves, is it worthwhile for us to pursue 10 while the 90 is still hanging there, or we turn our guns to face the 90 and the 10 will fix itself? Where is the 90, Ashley? 90 is in the governance.
Okay.
The entire leadership of the insurance.
Okay.
You want me to explain?
Sure.
We have these ghost hospitals, for example, that were paid money. These ghost hospitals were registered. They're actually companies first, registered by the registrar of businesses. They have certificate of incorporation. They have KRA PIN. They are registered.
So you can easily track them.
Yes. These ghost hospitals have been registered to operate as a facility at KMPDC. KMPDC is not run by facilities. Registration of business service is not run by facilities. These facilities, these ghost facilities, are contracted by SHA. There is a document signed. Who are these people? What are the faces behind these ghost hospitals? If we are serious fighting graft, we should have those faces out first. Because we can't fight an unknown enemy. And who has the mandate to expose these people? That is the 90%. How I wish if we would focus on the 90% of the problem of the medical fraud, and then we come up. Before we come in even to SHA and find who are these that approved these claims, approved these payments. How did it happen? Why is it that 3 weeks down the line after they had been all hue and cry in social media and wherever, we still have not seen one face of the owner of the ghost facilities? Yet, we are seeing 1,800 files being given to DCI. That is a problem. It makes me think that we are not serious in this war on graft. It's like we are deliberately bungling the war against graft because we actually don't have anybody to accuse.
Okay.
So we want to have someone say, oh, it is either was lost at the court did not listen to this, and we remain there with a lot of stories. Let me tell you something else, Ashley. If we are to win the battle against corruption, we must be very transparent. And we're going to be transparent right from the systems. You know, we already passed the place where we needed to have, verified the system and where it came from and whatever. We needed to have piloted this system. We needed to have looked at this system all around 360 so that we stop confusing people. But unless it was intended to fail, we should have had time and systems to prove this system. Dr. Ria just said here clear that even if we are using AI at the moment, we cannot depend on AI 100%. If you go to ChatGPT right now and ask a simple question, it will answer you, but there will be a disclaimer down there. If it was a legal question, it will tell you this is just a suggestion. If you want legal, find a lawyer to explain to you. If it is a medical thing, it will tell you this is just a suggestion. If you want the specific medical report, go and see a physician. AI is not 100%. And even if it is, we wouldn't have seen the minister handing over physical files. Because why do you remove a digital information, put it on paper, and then hand over to DCI? I mean, it should be the other way around. You should be digitalizing the paper and give DCI either a drive, a flash disk, or something like that. Again, why I'm saying this may not be a good fight for corruption and medical fraud is because we saw when the files were being given out, the minister and all those people will handle some files to show us that they are doing it with the name of the facility on top here. This facility, I doubt whether they have a letter telling them that they have been accused for fraud. Now we are reading their names in the media. They are being condemned and heard. What will happen if at the end of it all they are proven innocent? What became of the Directorate of Data Protection? Exactly. When a facility is being exposed and you are already condemned, yet you have not been given that fair chance of explaining yourself.
Okay. Madam, even as you weigh in on the issue of the lack of transparency by those who are in leadership, so then what happens to us Kenyans who are dependent on this health sector, considering we are seeing health CS refusing to answer questions during presses and when the media is available. We're also seeing the same government saying that, all these lamentations you're bringing to the table is just propaganda. Whether you like it or not, we will push ahead. But clearly, there's something wrong. What happens then?
For me, the way I look at it, how we get out of the doldrum, and for we, the bottom line, UHC, which then this SHA is supposed to drive, is meant for Kenyans. Access, quality care, and it is in Article 43 of our Constitution. So it's supposed to operationalize for Article 43. As a public, even for me, let me put myself in that way, the mistrust that has been created in the health sector right now is going to be the undoing of the health sector. Until that mistrust and communication is done, so that people begin to get confidence and again regain their confidence and trust the system is still going to be weakened. So the best thing for me, where we are right now, people need to be talking and talking factual. And even if the leadership is being flanked by professional, let people begin to speak what makes sense to Kenyans. Because right now it's a lot of mixed bag of many things that you do not know which one is right, which one. Even for me, you don't know which one is right, which one is wrong. Because for me, I'm no longer in active service, so I really don't know how to place it. But because I've worked in the system, then I begin to question certain things that I see that looks odd. Is it that we are being pushed this way to chase something so that something is still being sorted, something is not right somewhere? So we need time to sort it out, rather than coming out and say, hey, you Kenyans, this is the situation where we are. Because from where I sit, the envelope that started the SHA, I don't know how much of that total envelope, but one of the critical ingredients for UHC is you must have sustainable financing, and it's huge financing that you need to invest. The second, which we have not looked at, SHA is only looking at that component of health financing. It has not looked at the health system's infrastructure, which is human resource, commodity security, and as facilities that are working and have equipment. And then the last one is the insurance, apart from the monies that we need to have invested. And I think the calculation of that money had, at some point in 2018, had been calculated, and it was quite a huge amount of money. Then we leaped with what then we said was available. And look at what was said to have been provided for this financial year. I think it was 168 billion. What has been given by the Exchequer? I think it's 6.1. Now, look at that discrepancy. Are we able to deliver a service, a quality service, with that amount? But if there's a problem that there's no sustainability of financing, because another thing I want to put on the table is we had hoped that Kenyans were going to register in big numbers. Informal sector, which has about 80%, we thought that making this law mandatory, they were all going to be on board. Unfortunately for us, there are only 22 million Kenyans that have registered, but the people who are paying are between 4 to 5 million. So already we are under-resourced. So if we are under-resourced, are we able to talk about our problems nicely so that we see, are there things that we can do better? Because in the space of UHC, you want to do curative, preventive, you want to do rehabilitative and whatever. And I know that there are services that the two of those funds are being exchequer driven. So if the exchequer doesn't have enough money, are we having a conversation as Kenyans? What then do we do? And if our pool, because it works on a pool system, if you pay and I don't have, I could use your money because we are not going to be sick at the same time. Did we do our metrics correctly to give us the thing that was going to help us run a little bit sustainably before then we get, because the burden of the disease will be higher because we were more heavily on curative and we neglected preventive. Right now, because we are going down preventive, we are putting efforts on preventive. Maybe as we move certain years, maybe 5 years down the line, we will be seeing a saving that is coming from the preventive, and that means that we will start saving, we will start sustainability or financial sustainability. So you asked me a question, what would Kenyans think? Kenyans are confused right now because the right information, and when we started rollout of SHA, if you looked at what went through COVID, there was constant information to the public and people even that were giving posts that were everywhere. Have we said that this has been done the same level? Do people even know when I say, even when I'm going for, and I'm saying I'm going to do screening of cancer, what is the resource envelope that that is going on? Even the facility, I don't know, I'm not in a facility we could answer. But when you are sending your approval, you are requesting for pre-approval. I was wondering, even when we are talking about this fraud, this thing has already been pre-approved. You've been told how much money you have for a certain procedure, isn't it? So if you have been told, the system already has what they have told you. Is it that you have overshot, or how have you? So those are some of the things that are running into my head as a Kenyan, not as a practitioner, as a Kenyan. Because some people are telling you are told, okay, we will reimburse you, your claim, you can only be given 5. The same procedure, you find somebody has been given more. Yeah, last week, and I want to do real situation. Last week, somebody calls me and tells me, I am in a hospital. They have tried twice to get authorization. I can't get authorization. Can you intervene? Fortunately, I knew somebody somewhere. I called, and he said, our systems are not down. I needed just to confirm, is the system down? I'm told the system is not down. After a couple of hours, she tells me the authorization has come, and it was quite a huge amount. I must confess that was a huge amount. So I applaud SHA there, that particular person paid very little. They paid little because a big amount of theirs was covered. Another one calls a child who has already been done 1 surgery, is supposed to have 3 surgeries. Now these other 2 surgeries have not been approved. The child is waiting in hospital. Who is going to be left liable? Is the doctor, if this family decides to sue the doctor or a practitioner for negligence, who amongst these people, when we are haggling here, who is taking responsibility for the deteriorating life of this particular individual? So I think as Kenyans, we need to give, this is our life. We need to save life. People need to be candid about this thing and talk about it candidly. What can we do as Kenyans to make Kenyans much more healthier? Because the moment you sit in a hospital with an operation that should have been done like of yesterday, your life is deteriorating. And the life of your family is at a standstill.
Okay. Reverend, coming to you, the issue of pre-authorization, there has been so many challenges. As of today, were the challenges still there?
They were sorted around in the afternoon.
Okay.
Yeah, so the system came back, but for almost 6 hours, most of the day, the systems were down.
Okay.
Yeah, but at least in the afternoon, they came back.
So a bit of some good news.
Some good news,
Okay.
yes.
And even as we continue, there are some hospitals that are showing willingness to move out of SHA if the payment issues continue. What are the ramifications of a mass exodus?
Dire, I should say. And without a doubt, that's where we are heading to. Private sector actually re-strategizing now, which is a very dangerous point for the healthcare in the country. because you need to relook your tomorrow. How do you operate without cash flow? Remember, we had issues from the word go with reimbursement rates. For us, they are still too low, but we still accepted. Yeah, we said we can start and then keep on improving as we go on.
Okay.
For example, a normal delivery is paid at 10,000 shillings. It is a package, 10,000 shillings. A cesarean is 30,000 shillings. This is the rate that was being paid in 2017 with the NHIF. And we accepted because we also want to contribute to the wellness of the country. So we say the other things we will look at, and these other ones we can allow. And so there is a lot of goodwill that has been shown to the healthcare of the country from the private sector. We actually overreached to make sure that SHA works. Again, Ashley, if private sector leaves SHA, there will be a catastrophe. Looking at the maths that SHA is giving, or rather from the DHA, 61% of the people, of the claims raised are from private sector, which could loosely be translated at 60% of people go to private or non-state facilities. Yeah, so you would say that if 60% is denied, then we don't have a system.
Okay.
Yeah.
Ma'am, coming to you, I mean, we say in Kenya, we're not short of policies. The issue is implementation. In this case, is the issue the policy itself, or are we just not implementing it the way we're supposed to?
Two-pronged approach. The policy could have been tweaked at some point, because I think even as the policies were coming up, we raised issues then. Public participation was a bit ignored at some point. It ended up in court, which then delayed the process. And then I think that now maybe is being sorted out. The appeal was done, I think, but maybe it has gone through. So we are out there, and that's why I said we need to also look, when you start implementation and you see bottlenecks in the implementation, what you need to come and say, is it a policy issue, or is it the way the act was done? Because this act, even when it's done, from whichever corner it was done, did you carry along professionals? I know the professionals must have been there because they are advisors in the system. But are they advisors that looked at the different models of UHC that could work for this nation? And another thing that we are going to look at is this. We are saying leaving no one behind. Every Kenya is supposed to benefit. But there are areas, geographical areas, or even counties that already they are at a lower end. So even issues of quality, how as these issues that are being rolled out, taking in this matrix, I like the beauty of what they are saying. They're using this digital platform. I'd rather that we don't use input-based, but we use outcome-based, yeah? So that at least the money that you're investing is giving an outcome which you can then measure. How many women are we averting? How many deaths are we averting in a certain population, rather than we are just pushing in money? Because right now it is pushing in money.
Okay. Because we are pressed for time, we have like 4 minutes. Where are we at in terms of the Dispute Resolution Tribunal? You have been pushing. Any response?
The law says that the CS is supposed to appoint these people, the chair and the members. He has not done that.
Have you been in talks with him?
Yeah, we actually, as RUFA, we have written to him requesting for a meeting, but we haven't received any response.
Okay.
It's more than 6 weeks now.
All right. Briefly, I want us to talk about the UHC staff. I mean, just today, there was a deadlock of some sort, or maybe some people may think it's a progress of some sort between the Council of Governors and the national government on where they should head in the next 1 year or so, and the counties are saying they need 7.7 billion. Government, of course, keeps on saying there's no money. But I want us to look at it from a perspective of devolution, especially when it comes to managing a human resource. Was it better when the national government was in charge, or is it better now that it's devolved and there's sort of two levels of government handling it?
I don't know whether he wants to start because he drives, but I could start because
sure.
human resource for health is something that I've studied for a long time. When we went into the devolved system, health is devolved as far as we know it. But in practice, we have all these issues that we are talking, there's a disconnect between practice, between policy and practice. Mm-hmm. So there's a disconnect there, definitely. Okay. We have huge, nice policies, but the way implementation is taking place or the practice of it, I think is something that we need to look at. For me, it came at a time when, I think, was it during COVID? Or it came earlier. Mm. So when we had a national, we had an emergency, an epidemic for that matter, we needed to have men and women or skilled human resource or manpower to do what needed to be done. Good thing. But how was it done? In consultation, if it is devolved, and now we give them contractual obligation, I think there's also something that needs to be done. Right now, they are on contract, from what I hear. Of course, from what I hear, they are on contract. I watch news and I religiously watch what is going on in health. So yes, they were in contract. Now we want to make them permanent and pensionable. I want to ask, what is the staffing norm? We start from there. As the counties develop the staffing norm, what kind of human resource do they have? Are they within this pool that we want to make permanent, or we are just making permanent? For me, if I was the head of the director of HR, that's what I would start looking for, my staffing norm. Because each county has their different needs, yeah? Okay. So I guess I will stop there, but I think for definitely it is the county to determine, but if the resource is still held at the national level, resource needs to follow.
In 1 minute, before we get to Reverend, your final comment.
My one shot, my parting shot, I think, I'm appealing for Kenyans or for the ministry that is responsible for this saga, that people sit down. But I'm also appealing that the old professionals like myself, who I hear them murmuring somewhere at the outside, I think need to come and sort the profession. Okay. We are sinking. The health sector is sinking, and the earliest we come back and try to bring some voice of reason and just sit and talk, because that's what we used to do. We used to talk.
Okay, let's Reverend, talk. I'll let you have the final say in 1 minute.
Our problem clearly is not service providers. Our problem is actually money. In terms of, SHA collects very little. It collects about 5 billion and it pays claims about 10 billion. So SHA cannot meet that gap. So we will continue to have a systemic problem. So we only need to sit down in a very serious conversation and discuss how we can have SHA raise money. Okay. And we have all these ideas to give.
Clearly, a lot needs to be done. A lot has been said, but a lot more needs to be said. Let's hope that at the end of the day, we find a silver lining for the sake of the country and for the sake of Kenyans. Thank you so much for this informative conversation. Christine Sadia, Chairperson, Kenya Medical Women Association, and Reverend Joseph Kariuki, Vice Chairman at RUFA, which is the Rural and Urban Private Hospital Association. And thank you so much for being part of the conversation and trusting KTN this evening. I'm Ashley Mazuri on behalf of Jesse Rogers and our entire stellar crew. Have a good night.